You can just start whenever you're
Okay.
ready.
My name is Laura Yankee. I am the nurse manager in the Continuum of Care department over the inpatient nurse navigators. Currently, there are 11 nurse navigators over 8 specialty areas in the hospital. So you guys are very fortunate on 6 Roy Carver. You guys have 2. So Karen Hansen has teams A and B. And then she also covers family medicine and off service on the west end.
No, the east end.
Oh, the east end. Yeah, the east end, sorry. And Mary Sowers has team C and D, which is you guys. And then the west end that has the family medicine and the off service patients. So a lot of times the medicine service is really busy, and a lot of times your patients might be scattered throughout the hospital. So I did bring a list for you guys. You can pass around, each of you take one. That's a list of all the nurse navigators that are in the hospital and what floors they cover. Oftentimes your patients are going to land on a different floor, and if they do, you guys have a nurse navigator on those units, and so that they would very much like a lot of to get to know you and have contact with you while your patients are on their unit, because a lot of times the communication is difficult. It's very confusing to people that are not in the medicine service to keep track of who's got who, with residents, with the hospitalist team, to totally understand how the whole medicine service works. So by having you guys make early contact with them, really help them out. But then they do, they will the day, so they'll probably be seeking you out, and they might use Mary and Karen to figure out who you guys are. So, but basically the plan, the way the nurse navigators work is they kind of are the ones that are directing the flow of the patients through the hospitalization, trying to make at an optimal stay, make sure communication is good. There's a lot of different services involved with our patients, and so communication isn't always the greatest. So it's good to have one person that is a constant, that's here Monday through Friday. I think you guys both work 7 to 3:30, and it's touching base with the patients every day, touching bases with the team, touching bases with the interdisciplinary team. So I think every day you guys. The structure is a little bit different on 6 Roy Carver. 6 Roy Carver is a floor that does a lot of pilots and is always involved in new projects. So I think, one of the new projects that they've been doing, when did you guys start your afternoon huddles?
About 2 months.
3-4 months ago.
Okay. So they've got a new structure with their huddles being in the afternoon. Most floors you're going to get the huddles in the morning. 6 Roy Carver has been piloting doing them in the afternoon to see if that's going to help facilitate early morning discharges. And so I believe you guys do a little mini huddle, collecting information first thing in the morning, and then at 1:30 in the afternoon they do then the normal huddle. So usually at about 1:30 in the afternoon, Mary will
meet with Team D's.
So Mary meets with Team D at 1:30, and it's with the social worker, the Mary, the charge nurse, and
Social worker.
Yeah, so just
You already
the
said
3.
that, yeah.
So those 3 will meet with you guys to find out what the plan is the day for each patient that you guys have, and you go through anything that's going on, what tests they might be having, if there's issues with getting the test completed. That's when Mary can come in and help get things prioritized, get patients in quicker. If there's there's one thing the patient needs to get done before they can leave, we want to get that patient on the top of that list so that we can get the patient out as early as possible, because we don't want anybody staying here longer than they need to, and most patients don't want to. Therapies, I know work, what PT, did you guys PT and OT? I know therapy, PT works quite a bit with your patients, and if patients need placement, OT also gets involved.
Yes.
And so it's really important to get early identification of patients who are going to need to go somewhere after hospitalization, so they work closely with the therapist to figure out what the patient needs, and then with the social work, they find places for the patients to go to. So that's kind of a quick overview. They're also involved in a lot of projects, process improvement projects through the unit. A lot of stuff is filtered through the navigators to make it successful, because they're the ones that are the key to communication with everybody. They're talking to the nursing all the time, they're talking to the physicians, they're talking to the interdisciplinary team. So they're a good person. They're good people to start things with, and they're also with the patients all the time. So they do daily discharge phone calls. They try to do it within 24 to 72 hours post-discharge to follow up on all the patients who've gone home, make sure that they understand their discharge instructions, make sure they understand when their appointments are. They always make sure that anybody who's leaving the hospital has a set appointment in their hand that's in their thing, that they know exactly when they're supposed to be coming back. A thing that's going to be coming out soon is the discharge planner. They'll be spearheading that initiative when it comes out, and that's something that gets the patient involved in their discharge, where they talk about they're telling the hospital staff what it's their tool. They're writing on it, writing their questions. They're telling us on the tool, answering questions for us, like where they want meds filled, what they have for resources at home, who they have for help and things like that that will help us as we're making plans for them for going home. And with that tool, it's helping get the conversation going about discharge. And we want to get the conversation of discharge started on day 1 so that it's not a surprise when suddenly it's day 3 and they're going home. It's like, what? Why would I? We don't want anybody to be surprised about it. So we're planning for discharge the second they're admitted. And so that's something that's really good for you guys as physicians to get that conversation started. And when this planner gets out, we're going to be asking you guys to sign the planner with that you're the doctor. And by just doing that, a lot of times the families, the patients have had the perception that just by signing your name that you're spending so much time with them. And I mean, you could have spent 3 minutes, but because you signed your name on that planner and took the time to do that and see if they have any questions, it made them feel like it was 20 minutes. So just these small little things really can make you look good to the patient. So that's something that'll be coming out, and it kind of depends how some different pilots through the STEPS program work, and we're going to try to integrate that in a rollout with some of the pilots through the STEPS program. So you guys, I'm sure if you haven't heard about that yet, you'll be hearing more about that soon. So
things that help me in my position are knowing if a patient, like with our afternoon huddles, knowing the patient is hopefully going home the next day, to know that. That way we can find out, that they're getting transportation. We don't provide transportation unless there's an absolute need. They can't. But the sooner the patient knows that they're going, if you even say in a couple of days, we think you'll be going home by Friday, so you need to find out who's coming to get you, what time your ride can get here, things like that, rather than, oh, we can help you with the ride, because it's not going to happen.
But they also can't use a ride as an excuse. They don't have a ride. Oh, so you can stay till tomorrow if your ride can't come till tomorrow. We'll find them a ride instead of having them spend the night.
And sometimes it might work out that they can go to a hotel overnight until their family, they can provide their stay at the hotel. The other things are, you'll probably be meeting with the social worker, but everything that pertains to the patient's needs at discharge, whether it be a PICC line and IV antibiotics, the sooner we all know that, the sooner we'll have it all ready when the patient's medically ready to go, to involve the social worker. And then in the morning huddles, we touch base to make sure that the people that you said are going home that day are going, and any other appointments that need to, or scheduled things that we can help with for new patients as well. Tests, that type of thing. We need to know right away if a patient's going to need oxygen when they go home, if they didn't come in with it. The sooner that we start working on weaning them off their oxygen and finding out their walking desats, the better. Little things like that. As she said, setting up prior appointments before they leave. The sooner you can get those orders for follow-up within 1 to 2 weeks with a primary care physician, the sooner you get those ordered, the more prepared the unit clerk is to get those scheduled. And if they don't have a primary care physician, let me know if I can start helping them find somebody that they can follow up with. That if I have to call or something, sometimes I can do that. anything that, the better prepared we are, the smoother it is at discharge.
One thing we got to keep watching is making sure that the patient is at the acute level of care, and they still need to stay in the hospital, because once they're not, whoever their payer is going to stop paying. A lot of physicians, everybody wants to be nice. No one wants to upset a patient. No one wants to make them mad. And so a doctor's like, well, if you feel like going home today, that's really not a good idea, because there's a lot of patients that really don't want to go home and are very happy to stay here and be cared for, even though they don't really need this level of care. So, you just kind of got to be careful with how you word things with patients, and if they are ready, be saying, you will be medically ready tomorrow, this is what the plan is, and just kind of, stick to that. Obviously things change, and if they're not medically ready to leave, we're not going to send them. But if they no longer meet that acute level of care, we really need to keep moving on and watch. And when the physicians are saying, oh, you can stay another day because you want to, because you feel tired, it really puts the navigator in a bad position and the hospital, because then you've got them as the big bad person coming and say, no, you can't stay here, you're not acute, your insurance isn't going to pay for it, and you're going to be stuck with the bill, which can happen. And so we don't want and when they realize that, they're not, that makes them very upset too, and they don't want to get stuck with the bill. But then we would have avoided the whole situation had we not given them, oh, it's your choice whether you want to stay or not, because it's not a choice, it's whether they're acute or whether they're not, and they actually need to be here. So that's kind of one of those things. And I'm trying to think if there's anything we're missing. When Mary's not here, Karen will absorb her caseload, and she'll be your go-to person. Mm-hmm. And so she'll be there for huddles and situations like that, and they will help each other. If Mary's swamped and Karen's load is a little bit lighter, they will help each other. And then I'm always someone for when huge issues come up and the situations needs to be escalated, I'm someone that can come and help get the resources involved to help with some of the really difficult discharge situations, because they do come up. Mary and Karen also help with, we have transfers from outside hospitals that come in, and some of those patients are covered by a transfer agreement, and with that basically they'll come here for our specialty care. Once we are done, we will transfer them back to their hospital. Sometimes they're not really excited to get them back, and then Karen and Mary can kind of help with those situations.
Yeah, and as Laura said, I'm covering for Mary, so you'll be stuck with me when she's gone, but just always remember, sooner the better. That's what you just have to keep in mind, because even for PTOT, they look at their list at 8 in the morning. So if you wait till 1 or 2 to put the order in, they won't be seen that day.
Yeah, and their staffing is dictated by the number of new referrals and patients they have to see. So they could be getting pulled to another unit altogether, and so your therapy support for your floor could be down because you didn't put your orders in till late.
Exactly.
At the same time, if you know a patient's up and about, they prefer not to have a PT order.
If they really don't.
And if it just means, activity level and not necessarily physical therapy, just to make sure you put in an order to ambulate, and that's the nursing staff's responsibility, however you want it.
And nursing staff is really good at identifying patients that might need the physical therapy and the occupational therapy if they're concerned about the patients, because they've gotten them up and they've moved them and they know, ooh, it's not right, that there's no way that they're going to be safe at home. They'll kind of cue you and ask for those orders.
So in addition to sooner the better, I would just say you can never over communicate. You'll be getting a Volt iPhone, and that's how we communicate a lot through the day. So don't wait till 2 o'clock huddles or 1:30 huddles to alert us on anything.
Mm-hmm.
Just we pretty much live on the unit, so you'll find us and we'll be able to help you.
Do you guys have any questions for us?
So your role is like a case manager, because that's what I'm used to in my hospital. So, and you'll be dealing with the discharge planning and any insurance issues, transportation. Is that right?
So
Well,
with
insurance,
the social worker,
Social worker
Social
does.
worker will-
right.
okay.
I mean, it's a big team effort, and so the social work and nurse navigators work very closely together. They help a lot more with the clinical aspects, and the social work will help with the payer issues, the transportation, and getting like outside facilities set up. But a lot of times the clinical needs to go through these guys, because the social work doesn't completely understand what's all going on. They might be talking to outside facilities to explain things so that they understand and that they will accept the patient.
Okay.
And another easy way to kind of remember, like, who do I go to? A social worker or a care coordinator? You know, who do I go to? If you think of in-house, the clinical aspect, the facilitating the plan of care, that's us. And then out of the hospital is more so the social worker, even though we work as a team. So just remember in and out, and that'll help, you know, at least give you a start of who to start with.
But a lot of times, if people are going to be discharging home, and it's services like that are set up in their community, like they need their INRs checked, you know, that would be something Mary and Karen would help get set up so that it's getting followed with by their local physician.
All right. And do we have to put a concert for you in Epic, or
No.
so we have to call you?
No, they'll automatically be following
Okay.
every single patient
single
that
patient.
is on 6 Roy Carver.
And-
It'll be normally be Mary.
Okay.
And so if you need something, and remember Mary, she'll be on your Volt. Put her as one of your favorite people on your Volt. Get her pager number memorized. You'll wonder she's on that piece of paper.
Okay.
You might want to highlight her.
You'll know me.
And
I'll be there.
same with the social services, like they'll be following with every patient? Or?
Every morning, the social worker and I touch base with Team D to see if there are any updates on anybody's going home that we need to know about, you know, any home IVs, home feedings.
If they don't need anything, social worker might not be following them. If it's just going to be like a simple discharge home, they've got insurance, they've got a ride, everything seems good. But Mary will follow every single patient. Social work will kind of be as needed.
Got it.
I think there's a very nice setup. Not only to decrease the length of stay, but also to reduce the readmission rates if everything gets set up, discharge planning, social issues, appointments, therapy. So I think that would be great.
Yep,
Alright.
it's helped with decreasing the stay, but increased patient satisfaction
Yeah.
and decreased readmission. So you're exactly right.
I mean, it's good for everybody to have, that one person they know they can go to. And if Mary doesn't know the answers, she knows how to get it or knows how to get someone there. And if you're just having trouble getting someone in for a test, ask Mary. Mary knows who to call. She knows the resources. Ask them questions. I'm sure Karen's walking down the hall. She'd be happy to answer questions too, even if it's not one of her patients.
Yes, because I don't know everything, but I'm willing to find an answer for anything.
And if we cannot find anything, we'll try to find you.
There you go.
Okay, great.
And then just if off-service patients, if it's one of those units, it's the burn unit. You probably won't have a lot of patients go there because they're usually pretty full. The oncology unit usually has a lot of medicine overflow. Both the ODO. The 3 JP West and 4 JP West, both of those floors get a lot of medicine overflows. 4 Roy Carver ends up with a lot of medicine overflows. Right now they have 1 nurse navigator. They will have a second one come August. So then, basically they'll be split up east and west. 6J, which is the neuro floor, has 2 navigators, one's on east and one's on west. And so it's kind of divided there. And so a lot of times as the census is down on those floors, the medicine patients will come there. So I'm sure you will have patients on all the different floors and get to meet the navigators. And, if you contact them, they'll be thrilled to have like an update of what the plan is for the patient. Because a lot of times since they're rounding and doing their huddles early in the morning, they'll have their plans, but then they'll have like the outlier patients who they don't know, what's going on with. And if it's somebody that, hey, we need 1 test and we can discharge them today, let them know that, because that will really help them get things facilitated for you.
So, there are different services, for example, cardiovascular, hemo, and they must be having patients on different floors. So during huddle, everybody from, one representative, a hospital is from every service is there, or do you guys round separately with different services?
We just round with like your patients on only the patients on 6th Roy Carver.
Right.
We don't follow the patients that are on another floor that are on your team.
Right. That's why I wanted you to have that list. So if your patient is on 4 Roy Carver, you know that you should call Lauren, and Lauren can help you with that patient. And Lauren might, good chance that Lauren's probably going to be trying to track you down too, to find out, who's going on. And it's confusing with the hospitalist team that, because you guys are listed as the staff. But for most services, they have residents that are the ones following, and you don't call the staff, the person whose name is listed. You call the senior resident, or you call the R1, and so it's really hard to figure out. But you guys are on the medicine team D, but it doesn't click with people that team D is the hospitalist, and because your name is on it, you are the person following it. So it is confusing to I mean, I came from the neuro world, and I've just been in this position for a little while, and I've spent a lot of time with the medicine, you know, and learning about the different medicine teams and stuff, and I've, you know, the last month and a half, and I still have more to learn, but I'm starting to figure it out finally.
And
So.
if you would lose that piece of paper, don't panic. You can ask one of us. You can
Mhm.
say, hey, I got a patient on, you know, 6JC. Who do I call? We'll help you out.
We'll just take a picture and keep it in our
Yeah.
iPhone.
Well, there you go.
That'll work.
Plus,
Good idea.
I share an office with two of the nurse navigators from other floors, and sometimes they'll let me know if they're trying to get a hold of a doctor on my floor for a patient, and so I might come to you and say, your patient, you need to call Deb or
Yeah, yeah. If you
Anita.
ignore the pages, they'll hunt you down through them. So.
Do you have any other questions?
I think many questions will come
Will
up
come.
once we
That-
start
that was
working.
right.
A little overwhelmed. Yeah,
Yeah.
that's understandable.
But I mean, just remember that they're here as resources. You know, I'm here as a resource too, and if some big issues come up, usually I'll probably hear about it from them before I will from you guys. But you know, feel free to call me if there's any big issues that you need me to help with too.
Okay.
All right. Very
Thank you
good.
very much. Thanks a
meeting
Nice to meet you guys.
Likewise.